Good morning, friends. My name is Arunav and I'll be taking a lecture on movement disorders. So, movement disorders, the clinical presentation of movement disorders is complex and often variable, and establishing the correct diagnosis is often difficult. And this is very difficult even in hands of experienced movement disorder specialists. Accurate recognition based on clinical acumen is important for several reasons. The correct classification of type of movement disorders actually forms the basis for subsequent diagnostic process, and therefore the investigation workup can be greatly simplified once the type of movement disorder has been defined properly. Also, adequate classification often has prognostic implications. For example, essential tremor sometimes is mistaken for an early Parkinson's disease, but the prognosis is clearly different. Therefore, differentiating between the different types of movement disorders can have important consequences for the treatment. So we'll start. The first step is the MDS, that is the Movement Disorder Society, has given this classification of dividing movement disorders into hypokinetic and hyperkinetic disorders. So basically, if you see that the movement is insufficient, is less than normal, it can be akinetic, hypokinetic, or bradykinetic. If the movement disorder has too much of the movement, that is, it is hyperkinetic or dyskinetic, it can be further divided into jerky movements and non-jerky movements. So too much movement have been subclassified as being jerky movements which are non-rhythmic or non-jerky movements which are rhythmic. So the rhythmic or the non-jerky movement include the dystonia and the tremor, and these are basically regular rhythmic movements. Therefore, they basically have a rhythm to them. That is, a certain kind of regularity is associated with them. These are the rhythmic movements or the non-jerky movement disorders that are dystonia and tremors, and sometimes also acidosis is included in this. While on the other hand, we have erratic, jerky, and non-rhythmic movement disorders. These can be myoclonus, chorea, and tic disorders. So, beginning with the hyperkinetic movement disorders, first we'll be discussing the. Okay, so this is a table from Harrison where it gives definitions of the various movement disorders. So, we will go through each of these definitions, and hopefully by the end of the lecture, these definitions would be on your tips. So, the first hyperkinetic movement disorders would be rhythmic or non-rhythmic. The rhythmic would be tremors or dystonia. A tremor is a rhythmic oscillation of a body part due to intermittent muscle contractions, while a dystonia is an involuntary, patterned, sustained or repeated muscle contractions, often associated with twisting movement and abnormal posture. Acidosis, on the other hand, is slow distal breathing movements, involuntary movements, with a propensity to affect the arms and the hands. The non-rhythmic movement disorders include the chorea, which is a rapid, semi-purposeful, graceful, dance-like, non-patterned involuntary movements involving distal or proximal muscles. When the movements are of large amplitude and predominantly proximal distribution is there, the term Ballismus is used. Myoclonus, on the other hand, is sudden, brief, jerk-like rhythmic muscle twitches, while tics are brief, repeated, stew-type muscle contractions, can often be suppressed for a short time. Okay, so let us begin with tremors. Tremors are involuntary, rhythmic, and sinusoidal alternating movements of one or more body parts. You have to remember that it is an alternate contraction of agonist and antagonist, and the keyword in identifying tremor is rhythmicity. That is, oscillations occur at a regular frequency. Oscillations meaning that it rotates around a central axis. So for tremors, it has to be hyperkinetic movement. Second, it has to be rhythmic movement, and it has to be associated with the oscillating. It has to oscillate at a regular frequency, such that there is alternate contraction of agonist and antagonist. The Movement Disorder Society has classified these tremors on the basis of activation of tremor. There are many other classifications available, for example, in terms of body distribution and also in terms of frequency. But to decrease confusion, the Movement Disorder Society decided to classify it according to the moment of occurrence or the activation of tremor. So, if the activation of tremor occurs at rest, if it occurs at rest, it will be known as a rest tremor. While if the activation occurs at action, it is the tremor is during action. It is what we call action tremor. Now, the action tremor is further classified into kinetic, postural, or isometric, while the kinetic tremor is further classified into simple kinetic tremor, intention tremor, and task specific. So, if the action tremor is occurring during the course of the movement, it will be called as the kinetic tremor. While if the action tremor is present after attaining a particular posture, it will be called as action postural tremor. While if it occurs during isometric exercises, it will be known as isometric tremor. Okay, so as I have already told you, If the tremor is at rest, it's called rest tremor. And what does rest mean? So basically, when a body part is fully supported against the gravity, it will be defined that the body part is at rest. And if this hyperkinetic rhythmic movement is occurring at rest, it will be known as rest tremor. Example of an underlying disorder being Parkinson's disease. On the other hand, if the tremor is action tremor, it can be postural, that is occurring in the body part that assumes a posture against the gravity. Example would include physiological tremors, enhanced physiological tremors, for example, stress, endocrine disorders like hyperthyroidism or intoxications, and also essential tremors. Kinetic tremors are those which occur during motion. It can be simple kinetic, which simply means it occurs during entire movement trajectory. For example, an essential tremor. An intention kinetic tremor will be the one which progressively increases towards the intended target. Please note that a simple kinetic tremor would occur during the entire movement trajectory, while an intention tremor would be more towards the end of the action, or it progressively increases towards the intended target. And a classical example being cerebellar ataxia. While a task-specific kinetic tremor would occur only during specific activities. Example of dystonic writing tremor. Isometric isometric tremors are those which occurs during voluntary muscle contractions against a solid stationary resistance. And this can also be physiological or associated with other types of tremors. While combinations, basically these are mixed tremors. For example, patient with Parkinson's disease, for example, they not only have resting tremor, but also commonly show a postural tremor with higher frequency. Another example is the rubral host tremor. This is also known as the midbrain tremor, and typically has resting, postural, and even intention components. So coming back to this classification, if the tremor is at rest, it will be rest tremor. If it is on action, it can be kinetic or postural. Kinetic, if occurs throughout the range of motion, it will be simple kinetic tremor. If it progressively increases during the movement, it will be a intention tremor, and a task specific would be only during a specific task. But postural tremor can be position dependent also, and isometric tremor would be during isometric activities. Okay. So we'll see this video once. Okay. So what do you see here? So let us start with the basics. The movement, we can see that this is more than normal. So it is a hyperkinetic movement, one. Second, I told you we need to see if it is jerky or non-jerky. That is, is it rhythmic or is it non-rhythmic? I can see that this movement is rhythmic. It has a certain rhythm associated and has a regular movements, right? So it will be a rhythmic movement. Now, third thing I need to see that it is oscillatory and occurring at a particular frequency, right? And this is occurring at rest. So I can safely say that this is a rest tremor. Okay. So yes, it is hyperkinetic. Second, it is rhythmic. Third, it is oscillatory, occurring at the same frequency, and therefore it at rest. So this is a rest tremor, seen in a typical case of Parkinson's disease. Okay. So let's see this video. What is this showing to us? So I can see, okay, so let me describe this for you. So I can see a hand which is not moving on rest, but as soon as it goes towards the object, it is progressively increasing, and when it reaches the object, it is again increasing. But when it is holding the pen, again if it is at rest, it again goes. So this is in a slow motion. I can see there is no tremor at rest. When it goes towards the object, there are hyperkinetic rhythmic movements, oscillatory occurring at a particular frequency, and when he holds the pen, the tremors go away. Okay, so these are classic case of intention tremors. So yes, they are hyperkinetic, they are rhythmic, oscillatory, occurring at same frequency, more on reaching the target, and therefore these are resting tremors. These are intention tremors, characteristics in cerebellar diseases. Okay, so let's see what this video is about. So when the patient is asked to outstretch his hands in front of him, that is attaining a particular posture against gravity, we can see that there are fine rhythmic movements occurring here. There is a close-up showing the same thing. So again, we can see these movements. These are hyperkinetic. Definitely they are hyperkinetic. They are rhythmic. Yes, they are rhythmic. Let's see a close-up view again. So yes, they are oscillatory, occurring at the same frequency and only at a posture. So these are nothing but postural tremors. Example of postural tremors can be physiological or it can be essential tremors also. Okay. Now let's see what this video is about. Okay, so we can see someone writing on the paper, and there is a rhythmic movement disorder. There is a hyperkinetic abnormality occurring throughout the range of the motion. So basically, she's trying to pour this glass into another glass, and the movement is there throughout the range of the motion. Right. So let us see this again. So it is hyperkinetic, yes. It is rhythmic, yes. It is oscillatory, same frequency, yes. You see, this is also called as Archimedes spiral, and the patient is asked. Let's see this again. The patient is asked to draw on these lines in a circular manner, but the patient is not able to do so as there are oscillatory rhythmic hyperkinetic movements occurring throughout the range of the motion. Okay, so these we can say that these are simple kinetic tremors. These are kinetic tremors. Since they are occurring from the range of the motion, there will be simple kinetic tremors. The classic example being essential tremors. So this lady actually suffers from essential tremors. Okay. So another example we can see. Let's see this video as well. Okay. So we are asking the guy to pour water from the jug into the glass. Okay. So during this range of motion, we can see that there is a hyperkinetic rhythmic movement. Okay, and which is absent at rest. So at rest, the patient has no problem. So when he is doing some action, then there is this rhythmic hyperkinetic movement observed. Right. Okay. So again, this is hyperkinetic. Yes. Okay, it is occurring throughout the range of the body, throughout the range of the activity. It is oscillatory, same frequency, and throughout the range of the motion. So we can safely say this is a simple kinetic tremor, classically seen in essential tremors. Okay. So the Movement Disorder Society actually recommends to describe any tremor via two axes. So basically, this is done to maintain a uniformity in describing a tremor, right? So basically, if there are two clinicians sitting far apart in different countries, so that we have a uniform system in describing a tremor. So basically, the MDS recommends to describe any tremor by two axes. So axis 1 are clinical features and axis 2 are etiology. So any patient coming into our OPD, we should first describe in terms of axis 1. These includes historical features, for example, the age of onset. Because a person at the age of 30 or a person at the age of 60, they would be having a different problems. Temporal onset and evolution are also very important. Past medical history is very important. For example, patient may suffer from hyperthyroidism. A family history is important for genetic causes of tremors. And alcohol drug sensitivity is also important. Since certain tremors like essential tremors get relieved in alcohol, and certain drugs like lithium and valproate may cause tremors. The tremor characteristics like body distribution, is the tremor focal, is it generalized? Activation conditions very important, we have already studied that is it activate on rest, does it activate on motion, and tremor frequency also. Okay, associated signs include signs of systemic illness, neurological signs, and also soft signs. Additional laboratory tests also includes electrophysiological tests, structural imaging, receptor imaging, and serum and tissue biomarkers. The axis 2 includes the etiology. It can be acquired, genetically defined, or idiopathic as well. So this slide gives us the classification of tremors based on frequency. This classification is not very preferred because actually accurate assessment of tremor frequency is very difficult to accomplish in the clinic without a neurophysiological equipment, right? And the frequency spectrum may also vary between different tremor types and overlaps considerably. For example, attention tremors classically less than 10 Hz. Low to medium frequency tremors like 3 to 6 Hz would be Holmes tremor and Parkinson's disease rest tremor. Medium to high frequency tremors would be enhanced physiological tremors and also essential tremors. While very high frequency tremors are primary orthostatic tremor. I would like to tell you one point about primary orthostatic tremor. It is actually a tremor with the highest frequency. It is actually a leg tremor that is present only during standing, and it is characterized by an unusually high and a pathognomic tremor with a frequency of 14 to 18 Hz. Okay. The classification of tremors can also be based on amplitude. A low amplitude tremor could be present in an enhanced physiological tremor, while a large amplitude could be a Parkinsonian tremor or a Holmes tremor. Classification can also be in terms of body distribution, like it can be in head tremors, example in sessional tremors, cervical dystonias, cerebral degenerative disorders. Jaw tremors, example again in Parkinson's disease and essential tremors. Voice tremors again in essential tremors, while leg tremors may be seen in orthostatic tremors. Okay, so these are the various ways we can classify the tremors, but according to the Movement Disorder Society, the best way to classify them is according to the activation condition, which is rest tremor or kinetic tremor. Okay, so a short note about essential tremors. Essential tremors starts in a younger age group, but maximally manifest in 60 to 70-year age group. These are actually bilaterally symmetrical tremor affecting upper limbs, tongue and jaw, and mostly it's a postural action tremor. The diagnostic criteria simply states that the essential tremor is actually an isolated tremor syndrome of bilateral upper limb action tremor, at least 3 years of duration. Now you would ask me, T, what if the duration of tremor is less than 3 years? So in that case, we will call this tremor as an indeterminate tremor. And if it completes 3 years of duration, it will go to essential tremors. Third, definitely, it can be with or without tremors in other locations, example head, waist, or lower limbs. And absence of other neurological signs should be present, such as dystonia, ataxia, or Parkinsonism. So this would be what makes the essential tremor. Essential tremor is very important definition of Parkinson's disease ka tremor. So basically, essential tremor we know it's the onset is bilateral arm involvement and mostly an postural tremor. While Parkinson's disease characteristically is asymmetrical to begin with, and it's a unilateral tremor associated with stoop posture, shuffling gait, and memory loss. And the tremor characteristics is that is associated with purposeful movements, right? Because it's a simple kinetic action tremor, right? But Parkinson's disease has something called a stress tremor. So tremor would be at the arm and the side. There's something known as the latency period, which is immediate in case of an essential tremor and longer in case of Parkinson's disease. This is important because, for example, let's consider a typical resting tremor of Parkinson's disease. This resting tremor in the hands of patients of Parkinson's disease, it can also be observed when the patient is stretched out in front of the individual. So you'll be confused and is it a postural tremor or not? But in this case, in the Parkinson's disease, uh, this as soon as you outstretch your hands, there is a certain delay between the starting of the tremor again. For example, there is a resting tremor of the patient with Parkinson's disease. As he raises his hands towards a particular posture, the tremor would not be there, but it restarts after a certain latency. While essential tremor, actually, when the patient attains this posture, it will be immediately there. Right. So tremors coming immediately after assuming the posture is likely to be a postural tremor. But if it occurs after a delay of several seconds, it will be in the case of resting tremor Parkinson's disease. This delaying of several seconds in case of resting tremor is actually a phenomenon termed the resetting or a re-emergent tremor seen in Parkinson's disease. So coming back to the essential tremor, the aggravating factors include stress. While alcohol is a relieving factor for essential tremor, 50% of these patients have a positive family history, and a proposed pacemaker for stress tremor is cerebellum and the inferior olive. The treatment of essential tremors includes, if it is mild, there is no treatment is needed as such, but if it is interfering with the daily activities, beta blockers like propranolol are required. Primidone and other drugs like gabapentin, topiramate may also be required. If disabling, deep brain stimulation of the ventro-intermediate nucleus of thalamus may be required. There is also something known as a functional ultrasound thalamotomy. It is less invasive and nowadays it is more among the woods. So coming back to our first step, that was classifying movement disorders into hypokinetic and hyperkinetic. We have already studied that we can divide this into rhythmic and non-rhythmic. The rhythmic disorders can be dystonia or tremors. So after discussing tremors, now we will be discussing something known as dystonia. So dystonia is an involuntary, patterned, sustained or repeated muscle contraction, often associated with twisting movements and abdominal posture. So again, we will see that the movement will be hyperkinetic, it will be rhythmic, but this time, unlike the tremors, which had a fixed frequency and oscillations present, a dystonia is associated with a twisting movement and abnormal posture. And also dystonia is said to be brought out by voluntary movements, that is initiated or worsened by an action, and the muscle contraction actually extends to involve other muscle groups and body regions that were in the first place not required for the given action, right? So this phenomenon is known as overflow muscle activation. For example, for a particular work, we need flexors. So if flexors are needed for the work while doing the activity, but extensors may contract as well during that activity. So there is something known as the co-contraction of agonist and antagonist. Please know that tremor used to had alternate contraction of agonist and antagonist, but dystonia has a co-contraction of agonist and antagonist. So let's see what this video has for us. Okay, so we can see in this video that it's an hyperkinetic movement. Definitely, it is rhythmic. Yes, it is rhythmic. It is had a certain rhythm associated with it. These are twisting movements extending to other muscle groups also. There are twisting movements extending to other muscle groups also. So this is basically nothing but a oromandibular dystonia seen in this lady. Okay, let's see what this video has to offer us. So we asked the patient to turn his neck towards the left, and as he turns it towards the left, there is this hyperkinetic rhythmic movement, rhythmic movement. Okay, so now it is not there when he looks forward, but as he turns towards the left, it was there. Right. So again, how will we see? This is an hyperkinetic disorder. Yes, it is rhythmic and non-rhythmic. Definitely, it is rhythmic. These are twisting movements. Yes, and also it is also involving other muscle groups. So, and it is worsened by action also. As we tell the patient to look towards the left, it will get worsened, and this is nothing but cervical dystonia. So please note what exactly is happening here. So basically, there is a co-contraction of agonist and antagonist, and the agonist and antagonist muscle seems to pull to realign the head against the spastic or dystonic muscle. Right. Okay, so I want to discuss some phenomenon occurring with dystonias. So there is something known as sensory or just antagonistic, whereby the dystonia seems to attenuate by certain sensory tricks, such as touching the affected body part, and the person may discover that some sensation or sensory trick may actually help them to relieve dystonia. For example, in this image, we can see that this is a sensory trick in cervical dystonia, where the patient has found that keeping her right hand behind the neck helped her to keep the head straight, right? And after they found this, she kept the right elbow flexed so constantly, she actually developed a right ulnar neuropathy at the elbow. So this is known as a sensory trick. There is another phenomenon known as null point, whereby the patient tends to find some position or some angle at which the dystonia is relieved on his own. So some point is there with equal opposing muscle is here, just cancelling out the dystonia. This is known as a null point. Right. So the MDS again recommends two axes to define dystonia also, axis 1 and axis 2. The axis 1 would include the age of onset. Is it starting in infancy, childhood, adolescence, or adulthood? Body distribution, is the dystonia focal? Example, an oromandibular dystonia occurring only in the lower part of the chin and the lips. Is it segmental, affecting certain parts of the limbs? Is it multifocal? Is it generalized? Is it hemidystonia, affecting half part of the body? The temporal pattern is important to describe. Is the disease static or progressive? Is it persistent? Is it action specific? Is it diurnal? Diurnally is very important. We'll study something called Sigawa syndrome later, where the diurnal variation of dystonia is seen. Also, associated features may be present. For example, the dystonia may be isolated or it may be combined. For example, it may be combined with the Parkinson's disease or it may be combined with the Myoclonus. Right. The axis to describe should be described in terms of pathology and inheritance. And is it inherited, is it acquired, or is it idiopathic? So let's have a short discussion on the body distribution of dystonia. The focal dystonia, we have cervical dystonia. If the neck is flexed, it will be anterocolis. If it is extended, it will be retrocolic. If it is lateral, it will be laterocolis, while a twisting neck will be a torticollis. Blepharospasm is nothing but affecting the eyelids. An oromandibular dystonia affects the lower face, chin, and the tongue. Oromandibular plus blepharospasm together denotes something known as Meek syndrome. Okay, spasmodic dystonia may involve the laryngeal muscles, while lip dystonia will be affecting the writer's cramp. So again, we come to this lady. We can see that there is blepharospasm that is in the eyes, as well as orofacial dystonia. So this is actually a lady of Meek syndrome having both blepharospasm and orofacial dystonia. Right. So the dystonia can also be generalized. These generalized dystonia are often hereditary and are more in childhood and mostly of genetic etiology. The important genes involved are TOR1A, THAP1, ANO3 and GNAL. The dystonia can also be combined, for example, the dystonia plus other disorders like Parkinsonism or Myoclonus. So let's come to this another video in which let's see the video first. So what can you see? I can see that the movement is hyperkinetic. Yes, it is hyperkinetic. It has a certain rhythm associated with it. It is getting repeated. They are twisting movements. Their movement is getting extended to other muscle groups also. And is also worsened by action. So this is nothing but a cervical dystonia. This man is actually a case of GNL limitation. It's actually a generalized dystonia, which having a severe cervical dystonia, that is retrocollis, laterocollis, and also torticollis. A slight dystonic head tremor is also present, and there is a mild involvement of the oromandibular and ocular lesions. Please note that there is also proximal brachial dystonia with obvious elevation of the left shoulder. So this is nothing but a generalized dystonia, a man with GNL mutation. So this table gives us some basic monogenic forms of isolated and combined dystonia. The isolated dystonia, these are the various genes affected. and the locus names, and some additional distinguishing features. For example, the TOR1A gene with the DYT1 locus name occurs in childhood or adolescent, and is actually characteristically begins with lower limb and spares the facial and cervical region. So characteristic sparing of the facial cervical is characterized in the isolated form of dystonia, right? While this can also be combined, that is, dystonia can be combined with Parkinsonism or can be combined with Myoclonus. Dystonia with Parkinsonism has the following genes. This one is important, that is the GCH1 gene. This is nothing but the GTP cyclohydroxylase for dopamine synthesis, and therefore this very important point is this form of dystonia with Parkinsonism is actually dopa responsive. This is known as nothing but the Segawa syndrome. One more distinguishing feature is that this has a foot dystonia, which is followed by Parkinsonism, and this have a diurnal variation, that is the dystonia at often worsens during the night time. This is a characteristic of a dopa responsive dystonia, that is Segawa syndrome. Okay. Dystonia can also be present along with myoclonus. Example, the SGCE gene. It is nothing but the sarcoglycan gene mutation seen in the myoclonus, and this is often associated with other psychiatric illnesses. Please know that most of the disorders of dystonia are autosomal dominant, while autosomal X-linked disorders, this TF1 DYT3 gene, it is actually known as Lubac syndrome, which is X-linked. Okay. So coming next is complex dystonia, when the dystonia is actually a part of a larger syndrome. For example, Wilson's disease, Huntington's disease, Lesch-Nyhan syndrome, and drugs and toxins. Dystonia is basically a part of a larger syndrome known as complex dystonia. The treatment of dystonia is actually disease specific. Symptomatic treatment also exists. For example, using anticholinergics for example trihexyphenidyl, benztropine. Baclofen can also be used, which is a GABA agonist. Tetrabenzene can also be used. Botulinum toxin can also be used. It actually blocks the release of acetylcholine at the neuromuscular junction, and effect lasts for 3 to 6 months. And the person-to-person efficacy may be there. Deep brain stimulation of pallidum have been found efficacious for some patients. So coming back to our original table, we have studied that the hyperkinetic movement disorders have been classified as non-rhythmic or rhythmic. Both rhythmic disorders we have already studied, that is tremor or dystonia. How do we differentiate between them? Once we have come to the point that the movement is hyperkinetic and it is rhythmic. Next, we need to see that if the movement is sinusoidal, oscillatory, and basically there is alternate contraction of agonist and antagonist. Alternate contraction of agonist and antagonist seen in tremors, while co-contraction of agonist and antagonist, and when the movement extends to other muscle groups and body regions which are not actually required for the same action, it will be present in dystonia. Okay. So the MDS is also keeping acidosis inside the dystonia, but actually the acidosis is often seen with disorders, with coriform disorders. So this acidosis will be discussed later. So now coming to the jerky movements or the non-rhythmic movements, these are myoclonus, chorea, and tic disorders. Okay, so chorea is a rapid, semi-purposeful, graceful dance-like non-patterned involuntary movements involving distal or proximal muscle groups. These are actually defined as abrupt, unpredictable, and non-rhythmic movements resulting from a continuous random flow of muscle contractions. The choreography includes a constellation of randomly flowing movements which are individually jerky in nature. When the same choreiform movements are of larger amplitude and predominantly proximal distribution, the term ballism is often used. So in this video, let's just see this video, what we have for us. So I can see, okay, so these are random hyperkinetic movements. These are definitely non-rhythmic movements. These are, okay, so let us see this again. These are non-rhythmic, non-patterned movements, involuntary movements affecting distal muscle groups. These are very abrupt, unpredictable, as we can see, and again non-rhythmic, and a continuous random flow of muscle contractions may be seen, right? So yes, hyperkinetic. Second, we see this non-rhythmic. Yes. So now we're out. That is not tremor, not dystonia, right? Yes, they are semi-purposeful. Yes, they seem to be non-patterned, definitely. And in the video too, we will see that when the same patient is walking, again the movements are non-rhythmic, semi-purposeful, abrupt, and unpredictable. So this is nothing but chorea. So this patient is a chorea patient. So chorea, according to time course, can be classified as acute or chronic. When it is more than 1 year, it is taken as chronic. Mostly these are genetic causes. In adult, the most common genetic cause would be Huntington's disease, while in children, the most common genetic cause is benign hereditary chorea. The chorea can also be acute or subacute. It is mostly sporadic in nature. An acute chorea And acute chorea seen in adults are usually structural, metabolic, autoimmune infections or it is associated with drugs. While chorea, acute or subacute chorea in children would be a Sydenham's chorea. The following table gives us an exhaustive list of etiology of chorea. These can be structural lesions, which can include vascular causes, tumors or demyelinating lesions. These can be metabolic or endocrinal causes. For example, a non-ketotic hyperglycemia, hypocalcemia, hyponatremia or hyponatremia. A uremia can also result in a coriform disorder, acquired hepatocerebral degenerations, hyperthyroidism, and hypo or hyperparathyroidism. Infectious causes can also be present, for example, toxoplasmosis, HIV encephalopathy, and Paran diseases. Drug-induced are very important, like levodopa, cocaine, amphetamine, and anticonvulsants. While autoimmune causes are also important, for example, Sydenham's chorea, rheumatological diseases like SLE, APLA, and systemic sclerosis. While autoimmune neurological syndromes are also present. We can also remember the more common causes of chorea, biopneumonic chorea itself. The C standing for copper deposition, example in Wilson's disease in cirrhosis. H standing for Huntingtons chorea and hereditary conditions. O for estrogens, oral contraceptives and pregnancy. Drugs like neuroleptics. R for rheumatic fever like Sydenham's chorea. E for endocrine causes like hypercalcemia, hypocalcemia, hyperthyroidism. Also metabolic causes like uremia and strokes. And autoimmune obviously includes the SLE and antiphospholipid syndromes. So we will be studying shortly about a disease, this Huntington's disease. So Huntington's disease is a progressive neurodegenerative disease. It's actually a trinucleotide repeat expansion. CG repeat expansion results in accumulation of toxic polyglutamines, which result in loss of medium spiny neurons in the striatum, resulting in atrophy of caudate and putamen. It's an autosomal dominant disorder, and the age of onset is between 25 to 40 years of age. And this phenomenon known as anticipation seen, that is earlier presentation in subsequent generations. So the Huntington disease, the clinical features, the motor features obviously coriform movements are present. There can also be presence of dysarthria and gait disorders. Other non-motor features include subcortical dementia, oculomotor features, and also behavioral disturbances like depression, psychosis, and often patients have suicidal tendencies. If you see the brain of a patient, a normal brain would have a normal caudal nucleus bulging into the lateral ventricle, while the brain of a Huntington disease would have, due to the atrophy of this caudal nucleus, as we can see, these are the caudal nucleus. Due to their atrophy, the lateral ventricles seem to open, leading to something known as the boxcar ventricle. So this description has been compared to a boxcar, and therefore the description on an MRI on the radiology is termed as boxcar ventricle. And definitely genetic testing is needed for confirmation of the disease of Huntington's disease. So let's see what this we have. Okay, so we can see that the patient has a non-pattern involuntary movements, rapid. Definitely, they seem to be grace-like, dance-like, non-pattern involuntary movements. Abrupt, yes. Unpredictable, yes. Continuous random flow muscle contractions, yes. Yes. So again, if you go by the flow chart, yes, it is hyperkinetic. Definitely non-rhythmic. Semi-purposeful, not a certain pattern at all. Non-pattern. Abrupt, unpredictable, therefore chorea. Why these? So after non-rhythmic thing, we need to see these things. The movement should be semi-purposeful. It should be non-patterned. The non-pattern is very important because the dystonic movement that we are seeing in the rhythmic disorders were actually patterned. There was a kind of a pattern associated. But these coriform disorders are unpredictable. We can't predict what will happen next, right? And these seem to be non-patterned and abrupt and unpredictable. And these are nothing but chorea. So this is the patient of Huntington's disease. So treatment in Huntington disease, there is no disease modifying therapy associated. Symptomatic therapy does exist. For example, tetrabenazine, deutetrabenazine. Tetrabenazine is nothing but VMAT inhibitor. It is a vesicular monoamine inhibitor and inhibits the release of presynaptic dopamine. Treatment of associated behavioral disorders is also important. And deep brain stimulation of pallidum definitely associated with good effects for some patients. Quickly talking about Sydenham's chorea, also known as St. Vitus dance. It is an autoimmune chorea and often occurs after infection of group S streptococcal infection. The age of onset is typically 5 to 15 years of age, and the clinical features include an acute onset. Therefore, it is an acute disease, right? acute onset choreiform movements and often associated with behavioral disturbances as well. The chorea responds to dopamine blocking agents, valproic acid and carbamazepine, and they may reoccur in life. For example, when associated with pregnancy or treatment with sex hormones. So this is a patient of side-enhanced chorea, as I think I've shown this before also. So again, we can see it's a hyperkinetic movement. It is non-rhythmic, abrupt, unpredictable, rapid, non-patterned, and continuous random flow of muscle contraction are present. Right. So what about acidosis? So as I told you, acidosis in the according to the MDS, it is classified under rhythmic movements and dystonias. But I will teach you acidosis abhi because acidosis is often confused with chorea only, and also acidosis is often present along with choreiform disorders. So what is acidosis? Acidosis is a slow, continuous stream of slow, sinusoidal rhythm movements, typically of hands and feet. In acidosis, hyperkinesias are actually slower and more sustained and are larger in amplitude than chorea. So this is a very important point to differentiate chorea and acidosis. Is that acidosis is slower, more sustained, larger in amplitude. Most commonly seen together with chorea and dyskinetic motor fluctuations in Parkinson's disease. Acidosis is usually congenital and the result of a perinatal injury to the basal ganglia and may be present in association with other neurological deficits. It is also related to an excessive dopaminergic activity. So in this video, this is an acidosis video, which is showing continuous stream of slow sinusoidal rhythm movements, and definitely slower, sustained, and a larger amplitude as compared to chorea. Okay. So again, how to distinguish is that the acidosis, the movements are typically slow, twisting and writhing, associated with spasticity, mostly involving the face, neck, and distal extremities. Right. While choreiform movements are brief, they are very brief, rapid, jerky, and are very unpredictable. They occur at rest or during normal movement, and typically involving hand, lower arm, face, or the head. So basically, the acidosis will be slower, a larger amplitude, twisting movements, while these will be brief, rapid, and unpredictable. So these are the position fingers movements of acidosis. So as you can see, slow twisting rhythm movements are there. Right. So I will show you another feature video of
Next, we
acidosis
have
movements.
acidosis.
Okay. So again, you can see in this video there is an hyperkinetic movement disorder rest. It is seems to be non-rhythmic to me, but definitely it is slow twisting within kind of a movement, a larger amplitude than a choreiform movement. It's actually an acidosis. Right. And compared with chorea, as you can see, the choreiform movements are briefer. They are very rapid. They are brief and rapid, jerky, and very unpredictable. Right. Well, as I showed you pehle, the choreiform, the acidosis movements were slow, typically slow. They were twisting, they were rhythm movements, right? But these choreiform movements are brief, rapid, jerky, and unpredictable. So this is how you differentiate between acidosis and choreiform movements. So again, this is hyperkinetic non-rhythmic, semi-purposeful non-pattern. A non-pattern word being very important, while the core acidosis had a certain pattern associated with it also. It is unpredictable, abrupt, and this is nothing but chorea. So what is Ballismus and hemiballismus? I think I have already told you that when the movements are of larger amplitude and a predominantly proximal distribution, the term ballism is used. And there is also associated with flinging movements that are occurring. If these flinging movements are occurring on one side of the body, the term hemiballismus would be used, right? So these occur due to infarction or hemorrhage in the contralateral semithalamic nucleus, and hemiballismus is actually very difficult to treat, incredibly disabling, and sometimes can be fatal because of exhaustion. So this, let's see what we can see in this video.
Voluntary movement disorder.
Definitely there is a movement disorder. It is hyperkinetic. No, I cannot see any rhythm, so it is non-rhythmic. Affecting one part of the body, it is jerky, it is random, and more proximal flinging movements are there. I think this I can safely tell this is hemiballismus, right? So again, first you will see it is hyperkinetic, yes. Second you will see it is non-rhythmic or rhythmic. It is non-rhythmic, yes. Third you see it is semi-purposeful, yes. Non-patterned, one-sided. So now abhi yahan tak to we can see still here we can see, can this be chorea? Yes, this can be chorea. But the point differentiating chorea and hemiballismus would be one, this is more proximal. Second, it is a flinging kind of a movement. And in this it is very clear, since it is one sided, it is nothing but hemiballismus. Okay, so this is a table telling you the difference between chorea, ballismus and acidosis. As you know, acidosis is thoda alag in this too because this is slow movement. Acidosis is a slower, larger amplitude movement. it is breathing, and its propensity affecting upper limb is more, right? While chorea, ballismus are both rapid, both are involuntary, both are non-stereotypical, and both are semi-purposeful, non-purposeful. Like, how do you differentiate them? Chorea, as I told you, would be dance-like continuous movement disorder and more on the distal part, but ballismus is more on proximal, and a violent flinging movement is a characteristic which can help us to identify ballismus. While acidosis, as I already told you, slow, larger amplitude movements and breathing movements and affecting the upper limbs. So quickly, let's revise these three disorders. As you can see, the chorea is slow, involuntary, non-stereotypical movement, breathing movements affecting the upper limb. Okay, so let's see what this is. Okay, so one, definitely hyperkinetic movement disorder. Second, is it rhythmic or non-rhythmic? Obviously, it is definitely non-rhythmic. It is affecting multiple muscle groups. Yes, multiple muscle groups are involved. Very high amplitude, quick and jerky, proximal flinging movements. Yes, you are thinking right. It is Ballismus. So yes, hyperkinetic, rhythmic, non-rhythmic. It is non-rhythmic. Semi-purposeful, non-pattern, multiple muscle groups involved. Is it chorea or Ballismus? Large amplitude, proximal flinging in nature. It is Ballismus. Let's see this video.
Try to stay in perfect.
So you have to look very carefully. So I can see. Can you see this hand? Can you see this hand? Can you see this hand? Okay, so these are actually hyperkinetic disorder, but this is non-rhythmic. Non-rhythmic. Okay, you can be easily confused this with resting tremor. Please note that tremor is actually rhythmic movement. It has a certain rhythm associated with it, has a certain fixed frequency associated with it. But this has no frequency. It is non-rhythmic. You can see it is non-rhythmic. At one time it is faster, one time it is slow. It is non-rhythmic movement. So one thing is clear. It is not a tremor. Okay, so not a dystonia, it is also rhythmic. So now we have a non-rhythmic disorder, non-rhythmic hyperkinetic movement disorder. Okay, it is brief, it is rapid jerky, and it is unpredictable, right? When we ask the patient to stretch his hands, again we can see a brief, rapid, jerky movements. It's very unpredictable. I cannot tell ki this will happen or this will happen, right? So this more goes in favor of a chorea, right? It is brief, it is jerky, it is not slow, it is not rhythmic, it is not acidosis, it is not proximal, it is not flinging in nature. So I cannot say it is Ballismus also. So it more fits into chorea. So hyperkinetic, yes. Non-rhythmic, yes. Third, it is semi-purposeful, abrupt, unpredictable. This makes it chorea. So coming back to our favorite table, we are studying hyperkinetic movement disorders. It can be non-rhythmic or rhythmic. Rhythmic dystonia tremor already studied. Non-rhythmic we have already looked at chorea. We have looked at Ballism, and we have also discussed acidosis here. The two left jerky movements are left now are myoclonus and tic disorders. So myoclonus, it's a sudden, very brief, jerk-like, shock-like arrhythmic muscle twitches. These myoclonus are usually positive, that is caused by muscle contraction. So we will say what is negative myoclonus. Negative myoclonus is usually due to a brief loss or inhibition of muscular tone and characteristically known as asterixis, seen in uremic encephalopathy, hepatic encephalopathy, even in pseudonarcosis. Myoclonic muscle contractions are mostly accompanied by some movement of the affected body part. In contrast to, for example, fasciculations or myokymia, where the twitches remain within the affected body part. Right. So the myoclonus can also be classified according to distribution of the jerks. They can be focal, segmental, axial, multifocal, or generalized. According to the mode of presentation, they can be present at rest. They can be present during action. They can be present during stimulus. For example, this can be stimulus induced. For example, a sensory, visual, auditory, or emotional stimulus. There can be an anatomical source, or it can be also be classified on the basis of etiology to be a physiological myoclonus, essential epileptic, a symptomatic, or a functional myoclonus also. So this video, I can see
that throws us into the non-rhythmic category.
Can you see this is a non-rhythmic movement? Can you see this is a non-rhythmic movement? See, there is no pattern. It is not rhythmic. It is not rhythmic. It is not at a particular frequency. First, this was at. Are you getting my point? This is a non-rhythmic hyperkinetic disorder. One. Second, quick, jerky. Yes. So you would say, is this chorea? Definitely, this can be chorea. Definitely, this can be chorea. Definitely, this can be chorea. But as we are seeing, as the patient extends, as the patient extends, And now, can you see this flapping, this flaps? Can you see the flaps? Can you see the flaps? These are the flaps I am talking about. So this is nothing but negative myoclonus. This is aesthetics. This is negative myoclonus. Not a very good example to show you myoclonus because this you can easily be confused by chorea. You have to also see the history and the examination and the what other associated movement disorders are there. But definitely this you can appreciate the statistics, the flapping present. This is actually quick jerky and small amplitude negative myoclonus. Okay, so let's see what we have here. Okay, so this was a sudden, brief, jerk-like movement disorder, easily recognized as a myoclonus. This is actually a case of myoclonic epilepsy. Okay, so let's see what we have here. This is a small baby, and okay, did you notice something happened? Did you notice something happened? Did you notice something happened? Okay, this moment. So this sudden, very brief jerk, like shock-like arrhythmic twitches. This is actually nothing but a myoclonus, right? So myoclonus can be an essential myoclonus, that is a dystonia myoclonus combination. It can be an epileptic myoclonus, for example, JME, juvenile myoclonic epilepsy, or an epilepsia partialis continua. It can be progressive myoclonic epilepsies, for example, Lafora body disease, other causes also, and symptomatic myoclonus, that is symptom of some other disease. It can be post-hypoxic, anoxic myoclonus. It could be a dementing illness, example Alzheimer's, or it can be drugs or toxins. So let us see what we have here. Okay. Okay, so these are hyperkinetic movements. Yes. Are they rhythmic? Do they follow a rhythm? No, these are non-rhythmic movements. Okay. So what next? What next? What next? I can say they are very brief, very sudden. Again, shock-like movements. Okay. So these are nothing but myoclonic jerks, hyperkinetic and non-rhythmic, sudden brief like shock-like sensation. These are myoclonic jerks often seen in post-hypoxia. So this is nothing but a post-hypoxic myoclonic jerk. This is a patient post-CPCR revived and ventilated and due to hypoxia. So this is a post-hypoxic myoclonic jerks. Treatment of myoclonus is basically symptomatic. We can use drugs like clonazepam, levetiracetam, and valproate. Focal myoclonic jerks, we can use botulinum toxin also, and the treatment is basically disease and syndrome specific. Coming to the next jerky movement, hyperkinetic movement disorder, it is tics. Tics are brief, repeated stereotype muscular contraction. They can often be suppressed for a short time. Right? Tics can usually be largely suppressed for short periods by an effort of will. This point is very important because other movement disorders are usually involuntary and they are not suppressed. But these tics can actually be suppressed for short periods by effort of the patient's will. However, suppression of the tics typically comes at the expense of mounting internal inattention, leading to a rebound of tics afterwards. So tic disorders can be motor or vocal tics, right? So the motor tics can be simple motor tics, for example, blinking, head jerks. It could be a complex motor tics, for example, jumping, sniffing, or even head banging. The vocal tics can be simple vocal tics, for example, grunting, or it can be a complex vocal tics. It can be echolalia, that is the patient repeats someone else's voice. It could be palalia, that is patient repeating his own words. Corporalia, the patient can repeat an obscene language. Okay, so here we have a video from Tourette syndrome TikTok disorder awareness program, whereby this video is uploaded by certain patients having Tourette as they wanted to spread awareness. So
you might know that I have quite a few number ticks, like 5, 7, 25 and others. And I need to realize that counting out loud is super.
okay, so as you can see, hyperkinetic, non-rhythmic movements, very brief, will sustained, and these are nothing but vocal tics. Okay, so this was so something about Tourette syndrome. Tourette syndrome is a complex neurobehavioral disorder. The mean age of onset being 2 to 15 years of age and is often lessened and often dissipates in adults. Multiple motor tics are often accompanied by vocalizations and accompanied by behavioral disturbances also, like anxiety, depression, ADHD, and OCD. Some cases, there can be a consequence of autoimmune response to a beta hemolytic streptococcus infection. this syndrome known as PANDAS, that is pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. The treatment for it includes the first line treatment being the education behavioral therapy, and the next step is definitely pharmacotherapy. Tier 1 medication includes guanfacine, clonidine, topiramate, clonazepam, and baclofen, while Tier 2 medication includes antipsychotics, VMAT2 inhibitors, and others. And deep brain stimulation is also something which is under study. Next, we'll be reading something about drug-induced movement disorders. So, drug-induced movement disorders are primarily associated with drugs that block dopamine receptors, that are neuroleptics, or central dopaminergic transmission. Most commonly, these drugs are antipsychotics. Other drugs that may be associated are prochlorperazine and metoclopramide. These drug-induced movement disorders are divided according to presentation. These can be acute, subacute, or chronic. Acute drug-induced movement disorder, the most common is actually dystonia. So the acute drug-induced movement disorder presents as dystonia, and this dystonia is focal in adults while generalized in children. This occurs within minutes of exposure to drug, and treatment with anticholinergics like benztropine and benzodiazepines are there. While subacute drug-induced movement disorders are commonly present as akathisia, which is nothing but motor restlessness, while late drug-induced movement disorder have a tardive presentation. Months to years after the start of drug, this occurs, known as a tardive presentation of the drug-induced movement disorder. So this tardive presentation can be tardive dyskinesia, they can be tardive dystonia, tardive tics, or tardive myoclonus. So tardive dyskinesia is actually a combination of chorea and dystonia, and it is affecting mouth, lips, and tongue. It is more due to typical antipsychotics than atypical antipsychotics, and elderly females are more at risk. 1/3 cases of tardive dyskinesia actually remits 3 months after stopping of the drug. The treatment is obviously stopping the offended drug, but be sure we do not abruptly cease the drug. And FDA-approved treatment for tardive dyskinesia includes valbenazine and dentetrabenazine. So coming back to our favorite box, we were studying hyperkinetic movement disorders, right? So we told the first step would be to identify that it is a movement disorder. Second, we need to know it is hyperkinetic movement disorder. Third, we need to see if it is rhythmic or non-rhythmic. If it is rhythmic, it can be tremor or dystonia. If it is non-rhythmic, then we need to see is it tics, it is chorea, or is it Myoclonus. Okay. So now I am pretty sure this table would be very easy for you. So the tremor, what was tremor? Tremor was a rhythmic oscillation movement due to intermittent muscle contraction. So basically there was an alternate contraction of agonist and antagonist. Well, dystonia is also a rhythmic oscillatory movement of the body parts, but there is a repeated muscle contraction also there, which spreads. The twisting and abnormal posture also there, and there is an alternate. No, there is a co-contraction. Co-contraction of agonist and antagonist are there. Acidosis is a slow distal breathing movements, a larger amplitude, and dance like they are basically snake-like movements. And a propensity to affect arms and hands. While coriform movements, are not rhythmic jerky movements. These are rapid, semi-purposeful, non-patterned is a keyword. Non-patterned involuntary movements affecting the distal limbs. When the movements will be of larger amplitude and more proximal, flinging in nature, the term ballism should be used. Well, myoclonus is a kind of a non-rhythmic hyperkinetic disorder, which is sudden, brief, jerk-like, rhythmic muscle twitches are there. Well, tics is also non-rhythmic jerky disorder, which are brief, repeated stereotype muscle contractions, and importantly can be suppressed for a short time. Okay, so we can see there is a spectrum associated with these movement disorders, going from myoclonus to Ballismus, chorea, acidosis, and lastly dystonia. The movements are becoming less violent, they are becoming less jerky, less explosive. They're actually becoming smoother and more flowing and more sustained. And definitely we can differ these from tics in that these cannot be suppressed by voluntary control. Okay, so coming to hypokinetic movement disorders. Okay, so hypokinetic movement disorders, the literature uses the terms akinesia, bradykinesia, and hypokinesia very inconsistently. The Movement Disorder Society defines akinesia as an umbrella term for the symptom complex that can include bradykinesia and hypokinesia. Bradykinesia is nothing but slowness of the movement, while hypokinesia is a poverty of movement, that is, movements are smaller than they are tended to be. Right. So this is a very important flowchart telling you about hypokinesia. First and of all, you need to rule out other causes. You don't need to directly jump on Parkinsonism. You need to rule out other causes of hypokinesia, that is hypothyroidism, ankylosing spondylitis, a stiff person syndrome, a rheumatological condition, or other orthopedic conditions. First, once these are ruled out, next we will go to something known as Parkinsonism. Right. So what is Parkinsonism? Parkinsonism can be diagnosed by characteristic bradykinesia, which is slowing of the movement with at least one of the following, that is muscular rigidity, 4 to 6 Hz का rest tremor, and a postural instability. So bradykinesia present with one of the three of the following, that is muscular rigidity, a rest tremor, and postural instability, we can say that yes, it is a Parkinsonian syndrome. But what next? So once we have made a diagnosis of Parkinsonian syndrome, we need to see if it is associated with other features, other neurological features or not. If it is isolated, yes, and a good sustained response to levodopa is there, we can say yes, it is an idiopathic Parkinson's disease. Right. So
Psych.
let's
She's got
see
the
what
scenes.
is happening in this video. So as you can see, the patient is told to get up, open the door, and go outside, and she is doing it very slowly. She takes a lot of time to open the door. She has a stoop posture and a kind of a fascinating gait, right? Okay, so this is nothing but a bradykinetic movement. It's a slowness of the movement, right? So what is?
Hypomania. He's got a jaw tremor.
So as you can see, this is. I think you're expert in this already. This is a hyperkinetic movement. This is rhythmic. Definitely is a rhythm associated, and as present rest. So this is a rest tremor, characteristically seen in patient of Parkinson's disease. So clinical features of an idiopathic Parkinson's disease include tremors, which are usually asymmetric to begin. They decrease with activity, and these are termed as resting tremors, pill rolling tremors, and frequency are often 4 to 6 Hz. Rigidity can be cogwheel type, mostly in the upper limbs. Bradykinesia simply means slowing and difficulty in maintaining movements, while postural instability or gait abnormality is also present, which is nothing but a fascinating gait, that is rapid small steps with a tendency to run is present, slow to start walking with reduced arm swing, and an impaired balance on turning. So this picture is adequately telling you about the idiopathic Parkinson's disease. So this is, we can see a stoop posture, a masked facial expression, rigidity, reduced arm swinging, slightly flexed hips and knees, and shuffling and short step gait. So this is a characteristic idiopathic Parkinson's disease. So it is the second most common neurodegenerative disorder, the first being an Alzheimer's disease. In early, the age of onset is usually, the mean age of onset is 60 years. And we have already discussed the cardinal motor features of Parkinson's, which is bradykinesia, rest tremor, rigidity, and postural instability. Other motor features include micrographia, masked faces, reduced eye blinking, drooling, soft voice, dysphagia, and freezing. While non-motor features are also important features, non-motor features are also present in Parkinson's, like anosmia, sensory disturbances, mood disorders, sleep disturbances, and also autonomic disturbances. So coming back to this diagram, we have already read about idiopathic Parkinson's disease. But, what if the Parkinsonism we got is not isolated? If it is not isolated, we'd see that is it hereditary? Is it hereditary? If yes, we will think about certain hereditary-degenerative diseases like Huntingtons, Wilson's, mitochondrial cytopathies, neurocancer-cytosis, Lewy-Bag syndrome, Mercado-Joseph disease, many other disorders as hereditary-degenerative diseases. If it is not hereditary, we would be looking for some underlying systemic or neurological disease. If with Parkinsonism, we are finding an underlying neurological disease, then this is nothing but a secondary Parkinsonism, that is secondary to an underlying systemic or neurological disease. For example, it could be drug-induced Parkinsonism, yes. It can be normal pressure hydrocephalus, yes. It could be hypoxia or any sinus infection, metabolic encephalopathy, a brain trauma, paraneoplastic toxin, a cerebral vascular disorder, or even a psychogenic. If there is no underlying systemic neurological disease, not hereditary, not isolated, then we'll be thinking about something known as Parkinson's syndromes. So there are 4 DDs overall of Parkinsonism. First, it can be an idiopathic Parkinson's disease. Second, it could be hereditary-degenerative disease. Third, it could be a secondary Parkinsonism. And fourth, it could be a Parkinson plus syndrome. Okay, so these are nothing but the 4 DDs. Some features suggesting an atypical or secondary cause of Parkinsonism. So if suppose there is an early speech or gait impairment, so we'll be thinking about an atypical Parkinsonism. Suppose there is an exposure to neuroleptics, then obviously it is a drug-induced Parkinsonism. If there is an onset prior to age of 40, I'll be thinking about a genetic form of Parkinson's disease. If there is an associated liver disease, then there can be Wilson's, it could be non-Wilsonian hepatolenticule degeneration. If there may be associated early hallucinations and dementia with later development of Parkinson's disease, this is nothing but dementia with Lewy bodies. A diplopia or impaired down gaze with Parkinsonism suggests a diagnosis of progressive supranuclear palsy, while a poor or no response to inadequate trial of levodopa would be an atypical secondary Parkinsonism. Okay. So these are the key four atypical Parkinsonism disorders. Such small main features: dementia with Lewy bodies. They can be fluctuations, Parkinsonism, visual hallucination, REM sleep behavior disorder, a progressive supranuclear palsy. Tells about a supranuclear gaze palsy, axial rigidity, gait disorder, and bulbar symptoms. A corticobasal syndrome would have asymmetrical apoplaxia, dystonia myoclonus, cortical sensory findings, and alien hand limb phenomenon. While a multiple system trophy can be cerebral Parkinson type, can have ataxia, Parkinsonism, long track sign, and autonomic dysfunction. So this was the approach to hypokinesia. Okay, so now approach to diagnosis. Now you must be wondering, it is almost 1 hour, and why am I starting the approach now? So basically, what we have studied till now is the first step. This is the first step of the approach to diagnosis, and it is actually enough for us to know this at the postgraduate level. So the presence of one or more disorders and to identify all the subtypes of movement disorders. This is the first step of the approach to diagnosis of movement disorders, which we have already studied. Next is what we need to do is second, define the dominant movement disorders, because many times the movement disorders are present in combinations. So we need to define a dominant movement disorder. Second, we need to identify any associated neurological features, and more importantly, associated non-neurological features. All this together will make a clinically based syndrome. And once we have the syndrome, we will have a provisional diagnosis, do a diagnostic workup, and ultimately have a final diagnosis. So this is what we have: a systemic approach to diagnosis in patients presenting with movement disorders. So a short note on each of these. We have already studied how to identify the subtypes of movement disorders. We know that some disorders can actually occur in pure isolation. For example, essential tremor is a symmetrical action and postural tremor in the arms, but by definition without other neurological abnormalities. Some combinations immediately raise a specific diagnostic suspicion, such as a combination of dystonia and lightning myoclonic jerks, a characteristic of muscular dystonia, DYT11. Importantly, whenever patients present with a mixed movement disorder, always consider the possibility of adverse effects of medications, most commonly the dopamine receptor blocking agents such as neuroleptics. Next, we need to know what is a dominant movement disorder. Why? Because often recognizing a dominant movement disorder is often easiest in the early stages of the disease. In patients with more advanced disease, the originally dominant signs might become masked by a secondary disease complications or a newly emerging movement disorders. For example, in advanced stages of Huntington's disease, chorea is often no longer prominent, and other motor disorders like akinesia, rigidity, and dystonia may predominate. Determining the dominant movement disorder syndrome is an essential step as it stirs the differential diagnosis and determines the subsequent diagnostic trajectory. So these are some disorders and associated movement disorders associated. For example, dystonias are prominent in idiopathic dystonia. Chorea would be dominant in Huntington's in benign hereditary chorea. Tremors would be it's essential tremors only. It's actually presents as an accelerated tremor syndrome. Myoclonus would be an essential myoclonus in post-anoxic myoclonus and drug-induced myoclonus. Tics are a prominent disorder in Tourette syndrome. While frequently associated movement disorders like Wilson's disease and Parkinson's disease, frequency will have presence of dystonia. Huntington disease frequently will have chorea associated. Parkinson's disease and Wilson's frequently can have tremor also. Multi-system atrophy, that is a typical Parkinson's syndrome, frequently we have myoclonus may be associated. And neurocancer frequently observed is tics. So these may help us to reach a certain diagnosis. So these are a few tables I have taken from the book called Principles and Practices of Movement Disorders by Fan and Jankovic. And you don't need to go into details, but a rough idea that the movements can also be paroxysmal, continual or continuous. So proximal is they come and go, come and go, come and go, and they occur very rarely. They are not very often. Well, continual is something which means coming over and over again, coming over and over again. Comes, stops, comes, stops, comes, stops. A continuous hyperkinesia would be it comes without stopping. That is, it is unbroken. It is consistently present, right? So paroxysmal hyperkinesia can be tics. It could be something known as a paroxysmal kinesogenic dyskinesia. It could be a paroxysmal ataxia, it could be paroxysmal tremor also, right? A continual that is occurs over and over again can be a ballism, can be chorea, can be dystonic movement, can be myoclonus, and most of the disorders are falling into this category. While a continuous hyperkinesia can be an abdominal dyskinesia, it can be acidosis, tremors, a dystonic posture, right? So hyperkinesia can also be present while being asleep, right? So something which these can be disorders which are appearing during sleep, disappears when awakened. So these are present only when the patient is sleeping. So these can be example hypnogonic dyskinesias, periodic movements in sleep, and even REM sleep behavior disorders are these appear only during sleep. Some disorders persist during sleep. That is, yes, they are present during day when the patient is awoke. They also persist during sleep. For example, ocular myoclonus, spinal myoclonus, moving toes, myokymia, and neuromyotonia. While most of the disorders and all of the other disorders, they are usually present when the patient is awake, and they diminish when the patient is asleep. Right. So we have already studied that the disorders can be at the rest, at action, and both at rest and action. Okay, so the next step we need to do is identify an associated neurological feature. So what are the associated features? Please note that the complexity of a clinical picture actually increases when the patient is exhibiting additional neurological features. But we should actually take advantage of this situation, as these associated features can provide important clues about the underlying etiology. For example, if suppose a patient has a diagnosis of an autosomal recessive ataxic telangiectasia, examining the eyes for oculomotor hyperaxia and also telangiectasia in these patients, which actually had chorea and ataxia, may lead to a diagnosis. For example, in patient of Wilson disease, finding of cave rings, or in the patient of multiple system atrophy, finding of an early and prominent autonomic dysfunction, whereas in the otherwise patient of Parkinsonism should raise a suspicion of multiple system atrophy. So commonly seen mixed movement disorders, for example, in Parkinson or atypical Parkinsonism, tremor and akinesia may coexist. In multiple system atrophy, as already seen, Parkinsonism may be associated with ataxia, prominent autonomic dysfunction, spasticity and myoclonus. In PSP, that is progressive supranuclear palsy, it may be associated with the vertical supranuclear gaze palsy and falls, and symmetrical Parkinsonism also. In cortical-basal degeneration, there are a variety of disorders like akinesia, rigidity, myoclonus, and even dystonia may occur. Huntington's disease may have chorea, but they may also have dystonia and bradykinesia. Wilson disease usually has tremors, at rest and postural tremors. It may have dystonia also, while mitochondrial diseases may have ataxia and myoclonus also. So we also need to identify non-neurological features, right? So okay, so the commonly associated movement disorder mimics are there. So we need to note that these are a range of conditions where both neurological and non-neurological conditions which can mimic various movement disorders, and therefore it is vital not to miss these lookalikes. For example, mimics of a Parkinsonism, the patient may actually be suffering from depression. That is why he is moving slowly, and there is a bradykinesia associated. There can be an obsessive slowness. There can be hypothyroidism. There can be spasticity. There can be a frozen shoulder and a catatonia. The mimics of a craniocervical dystonia, the patient may have a retropharyngeal abscess. Therefore, it seems like the patient has a torticollis, but he actually has an abscess lying into his posterior neck wall. There could be an atlantoaxial subluxation. There can be a congenital muscular torticollis. There can be a space occupying lesion in the posterior fossa. Mimics of limb dystonia, for example, there may be a contraction in the limb. There may be spastic limb. There can be mystonia. There can be neuromyotonia. There can be a stiff person syndrome. It could be a seizure. It could be an epilepsy partial continua, whereby the limb gets stiff and dystonic. Facial dystonia, the patient may have ptosis. The patient may have trismus. Myotonia, tetanic spasms. But mimics of myoclonus includes again tics, tremors, fasciculations, and also myokymia, and also chorea. Okay. So this was the approach to diagnosis in the patient with movement disorders. First and of all, we need to know the presence of one or more movement disorders. We need to identify the subtype movement disorders. We need to differentiate: is it hypokinetic? Is it hyperkinetic? If it is hyperkinetic, we need to see if it is jerky, that is non-rhythmic, or is it rhythmic. We need to see if it is rhythmic, is it dystonia, is it tremor. We need to see if it is non-rhythmic. We need to see it is myoclonus, it is chorea, it is tics. If it is a hypokinetic movement disorder, we need to first rule out the other causes of hypokinetism, and then we need to see if it is falling in Parkinsonism or not. If it is a Parkinsonian feature, then is it isolated? Is it an idiopathic Parkinson's disease? Is it hereditary? Is it a secondary Parkinsonism, or is it an atypical Parkinson disorder? So we need to see all this to come to a diagnosis. So next we need to identify and define a dominant movement disorder. We do identify neurological features and do identify associated non-neurological features. together come together to form a clinically based syndrome, have a provisional diagnosis. Diagnostic workup should be done accordingly, and then come to a final diagnosis. So let's have some quiz. I will be showing you some videos, and let's see how much have you gained from a lecture, and let's see how you perform. Right. So the first video I have is this.
And
So
then lastly, we've got our
So what you can do is you can pause the video and look at this again and think what it is, and then I will tell you the answer. So this is, as you can see, this is a hyperkinetic movement. Yes. Is it rhythmic? Yes, it is rhythmic. It is oscillatory. It is oscillatory. It is having a same frequency, and it is present at posture. It is actually postural, right? So this is a postural tremor, and it is an action kinetic. It is an action postural tremor, and seen most commonly in essential tremors, right? So second video, let's see what this is. Okay, so just notice what this was. So again, this is a non-rhythmic movement. It is jerky. It is very sudden, very brief, shock-like. This is actually a myoclonus, and this particularly is actually a physiological myoclonus, and may actually occur when the person is falling asleep and during the early sleep phases. This is the physiological myoclonus. So let's see if you can identify this.
Tell me again about how long all this is. This is.
Okay, so let's see this again.
Tell me again about how long all this is. This is. I've had motor tics since I was a child.
Okay, so this is, as the patient himself told, this is motor tics. So how do you know? So this is non-rhythmic, yes. They are jerky, yes. Please note that they were brief, they were repeated muscle contractions, they were occurring, right? And you may confuse this with dystonia, but do remember that
Tell me again about how long.
the person is able to suppress these movements due to his voluntary will, right? And this is a motor plus vocal, both suppressed, right?
This motor
So it's
tics.
nothing but vocal tics. Okay, let us look at this video. Okay, so this is a tremor. This is a tremor. Why is this a tremor? Why is this a tremor? Because it is present at. It is hyperkinetic. It is rhythmic. It is occurring at rest. So this is a resting tremor. Yes. So let's see what happens when he assumes a posture. So when he raises his hands, the tremor disappears. Since the tremor is disappearing, so this is not a postural tremor, right? So this is a resting tremor, characteristically seen in patients with Parkinson's disease. Okay, so let's see what this is. Okay, so this seems to be a non-rhythmic movement. Yes, non-rhythmic movement, kind of one-sided. Okay, non-rhythmic movement, one-sided, semi-purposeful. Yes, non-pattern, definitely no pattern associated. No pattern associated. So this can this be chorea? Yes, this can be chorea. This is chorea or Ballismus. So how do you differentiate? 1 second, one is it proximal? Yes, it is proximal. It is of large amplitude and it is flinging in nature. So this is nothing but Ballismus. Because it is involving one part of the body, it is actually Ballismus. Okay. So let's see. This is an easy one. What this is? This is. So friends, as you can see, this is a hyperkinetic. Yes, it is a rhythmic movement. This is a rhythmic movement. Yes, it is occurring at the same frequency each time, and it increases more on achieving a target. Right? It is a action. It is a action a tremor. It is occurring during movement. It actually is increasing as it reaches the target. So this is nothing but an intention tremor, seen in cerebral disorders. Okay, so let us see what this is. Okay, let's see this once again. So this is a hyperkinetic movement. Yes. Non-rhythmic or rhythmic? This is non-rhythmic, right? Non-rhythmic movements, no rhythm or no regularities associated with it. They seem to be non-patterned, no particular pattern associated with it. They are semi-purposeful, yes, and very abrupt. These movements are very abrupt, and continuous flow is there. Sometimes legs, sometimes in the hands, very unpredictable, right? Very non-rhythmic, very non-patterned, right? So this is nothing but this is chorea. This is chorea. Okay. So let's just see what
Left
this is.
sternomastoid muscle hypertrophy also exists.
Okay, so what just happened? What just happened? So this is a hyperkinetic, yes. Is it rhythmic? Yes. Every time it's same kind of a movement, it has a rhythm associated with it. Twisting movements, extension to other muscle groups. Twisting movements, attention to other muscle groups. So this is a dystonia. This is the focal cervical dystonia, more specifically a retrocollis because of hyperextension towards the back. But what is happening abhi? Dekho, what is this? So this is something known as sensory trick, as I already told you, that the patient is actually finding a sensation. So when he's touching his finger to his left middle cheek, his dystonia disappears. So this is often the patient tends to find the sensory tricks to help them relieve the dystonia. This is a sensory trick involving the touching of finger to the left middle cheek. Okay. So what is this?
When the gait is
Okay, so as you can see, the patient is walking very slowly. He's very slow, very slow. Slowness of movement. So this is bradykinesia. This is bradykinesia, right? So there is slowness of movement is there. Yes. So it is Parkinsonism. It is Parkinsonism. So yes, there is bradykinesia. Yes, you can see that there is a tremor. There is a tremor occurring at rest. Occurring at rest. So this is a resting tremor, bradykinesia, a fascinating gait. So this appears to be Parkinsonism. Parkinsonism. So further with history, we can see this can be an atypical Parkinson's syndrome. It could be an idiopathic Parkinson's disease. It could be anything. Okay. So this is the last.
So right off the
Let's see
bat,
what
it
is
seems like
happening
it's
here. So though there seems to be okay. Let's just see the video pura first. Okay, I think I need to explain this. Basically, what the patient is doing is when we are telling the patient to assume a particular posture, we can see there is a tremor in the right hand, right? There is a tremor in the right hand, and we tell the patient to do such activities with the left hand, right? We tell the patient to do such activities with the left normal hand so that he gets distracted. And ideally, if it is an actually a tremor, the tremor frequency should not reduce. The tremor should not reduce. It should still be a hyperkinetic rhythmic tremor as it was before. Okay. So, but in this patient, what is happening in this patient? There is rhythmicity. There is rhythmicity. There is rhythmicity associated in this tremor, right? There is rhythmicity. This is definitely a resting tremor. Resting tremor is there. Also, posture tremor is there. So, there is also there in posture. It is there in rest. It is also there in posture. But as we tell the patient, in his left hand to perform certain activities, I can see that the rhythmicity has changed. The movement has become very irregular. The rhythmicity has changed. In fact, the tremor has reduced. The tremor has reduced. So, in fact, this is the tremor. Is this a tremor or not? So, we are now confused. Was it a tremor at the first hand? Was this a tremor? Because the patient is no longer maintaining the rhythmicity of the tremor. Okay. So, what happens next? As we tell the patient to assume this posture, we can see that there is the tremor is there in the y-axis. The tremor is there in the y-axis. Change of posture results in tremor. Now it is occurring in the x-axis. So the change of axis of this movement does not fit into any category. The axis should not change if it had been a tremor. So this is actually not fitting into any category. So this is nothing but a psychogenic tremor, right? So we need to keep in mind that the tremor can also be psychogenic if it is not fitting into any category. Okay, so there are certain acknowledgements and references I would like to give. For example, certain books like Harrison's, certain articles, for example, the clinical approach to movement disorders, book by Jankovic, book by Bradley, De Jong's numerical examination, and certain videos that really have helped me, which I have cropped and put in this video, and I have put credit for each of the videos, and these channels have really helped me to put forward these videos for you. So thank you so much, all of you, for attending my lecture. And for similar lectures, you can subscribe to my channel. This is my name, Arunav Garg, and you can find many more educational videos there. Thank you so much.